Now we'll delve into a condition that possesses a significant clinical challenge, HSP. Known for its hallmark rash and multi-system involvement, HSP often requires careful clinical judgment, and our next speaker will guide us through it. I welcome Dr. Anju Singh, Consultant Pediatric Rheumatologist, Madhukar Hospital, Children's Hospital, Delhi, and Artemis Hospital, Gurugram.
Good morning, everyone. It had been a great academic feast for all of us in the past 2 days, and I would like to add something to that feast. I hope it will be an informative session. At the outset, I would like to thank the organizers for giving me the opportunity to talk about a clinical condition which is commonly been seen by all of us in our day-to-day clinical practice. So I will be talking about when it is and when is it not Henoch showing purpura, that is HSP. So if HSP, we know Henoch showing purpura is an eponym which has been derived after the two German physicians, but in 2012 it has been renamed to IgA vasculitis because it is primarily IgA mediated immune complex leukocytoclastic vasculitis. So if we childhood primary vasculitis has been classified on the basis of the size and extent of blood vessel involvement. So we can have predominantly large vessel vasculitis, medium vessel vasculitis, and small vessel vasculitis. And HSP falls in the category of small vessel immune complex mediated vasculitis. So it is the most common childhood vasculitis, so and followed by Kawasaki disease. Among all the childhood vasculitis, it is the Kawasaki disease and HSP which have acute presentation. Rest of the vasculitis usually have chronic indolent clinical course. And it is important to add the term non-thrombocytopenic small vessel vasculitis because we have very close differentials of various hematological conditions, and so that's why it is an acute non-thrombocytopenic small vessel vasculitis. And then it is again important to talk about the histopathology because here we see leukocytoclastic vasculitis. So leukocytoclastic classes is a pathological finding, it is not a diagnosis. It can be seen in various clinical conditions and various rheumatological conditions. But what is important to know in this disease that it is a IgA immune complex mediated leukocytoclastic vasculitis. So if we talk about the pathogenesis, we all know that there is a four-hit hypothesis behind the pathogenesis of this disease. What is the first hit? The first is the presence of defective IgA molecule in the body in the children who are likely to develop HSP, and the formation of autoantibody IgG molecule against this IgA defective antibody. And when will it happen? It will happen when the child is going to have any, there will be a trigger factor in the form of any viral infection, respiratory tract infection, or most common bacterial infection that is seen in the pathogenesis is the preceding streptococcus sore throat infection. Sometimes it can be following drug exposure or insect bite also. So there is a formation of immune complex, that is the third hit. And what is the fourth hit? Fourth hit is the deposition of this circulating immune complex in various organs. So what are the most common organs to be affected? So the most common, we all know, it is the skin, and followed by the musculoskeletal system, and then we have gastrointestinal tract system and kidney. So to answer this question, when it is and when it is not HSP, we need to know the four clinical parameters. And these four clinical parameters are not only important from HSP point of view, but for any clinical condition. So what is the epidemiology of the disease? What is the most common age of presentation? And what are the typical clinical features seen? Then what are the typical laboratory findings that we observe in these kids? And if we're still not able to arrive at the diagnosis, then can histopathology help in these kids? So I'll go to each parameter one by one so as to understand how these children present to us. So in the epidemiology, we know that all primary vasculitis usually have a male predominance. Similarly, we see in HSP as well, though there is a slight male predominance, and about more than 90% of children present between 2 to 10 years of age. So the outliers are those who present less than 2 years or more than 10 years. But the important point to remember over here, though the incidence decreases with age, but severity increases with age. So we have a beautiful article from SGPGI who have compared that, led by Dr. Amita ma'am, that children, teenagers are more likely to have a disease similar to that of adults. So, and we know adults have a more severe presentation, and what do I mean by more severe presentation? That they are more likely to have kidney involvement. And it is the kidney is the organ in HSP which carries the long-term prognosis. So we can say the adolescents are more likely to have more differentials if they are having a clinical picture of HSP. So we need to be vigilant in adolescents who are presenting with purpuric rashes. So about the clinical features, we follow this latest classification criteria given for IgA vasculitis in 2010. So the mandatory feature we all know is the presence of skin involvement. Skin involvement can be, there can be variable presentation in the skin, which I will be discussing later with various case scenarios. Along with that, we should have one of the three most common organ affections. So either it can be MSK involvement, or there can be GIT vasculitis, or nephritis. And still inconclusive, then we have to go ahead with the histopathology. So what are the laboratory findings? I would re-emphasize the fact that most of the rheumatological conditions are clinical diagnosis. As my previous speaker rightly said, that we don't need sophisticated investigations in our kids. We need to take detailed history and examination to arrive a particular rheumatic condition. So most of the laboratory findings in IgA vasculitis is normal, though thrombocytosis is a common finding that we observe. And if there are severe manifestation, we can have significant finding in the lab parameters as well, in the form of normocytic normochromic anemia, leukocytosis, high ESR, CRP, hyperbuminemia, or stool can be positive for occult blood, and urine abnormalities in the form of active sediments in the urine. And so histopathology is another important part to be discussed over here. When do we go for the skin biopsy or kidney biopsy? When there, so there have been guidelines, there have been indications which have been given by SHARE initiative. And as per these indications, that if a child has got incomplete presentation, or a child has got atypical presentation, or a child has got, or a child is presenting where alternative diagnoses have got the upper hand. So there we may need to go with the skin biopsy, and we know that the leukocytoclastic vasculitis seen in this disease is different from other primary vasculitis. There we see IgG immune complex deposits, but here we see IgA immune complex deposit on the direct immunofluorescence. And kidney biopsy, I think my colleague is going to discuss where we should go for the kidney biopsy. So I will go through 4 basic cases, and I know we all are well versed with the disease, so it will be just small cases I will be talking about. So this is about a 6-year-old boy who came to our OPD with the purpuric rashes, pain in knees, and swelling of hand and feet for 3 days. So I think we all can guess it is a simple case of HSP having a mandatory feature of purpura in a boy who is falling in the common age group, and he's having arthralgia, and he's having swelling of hand and feet. So this swelling of hand and feet, we all know, is because of angioedema and not because of the kidney involvement. So in fact, if at all we investigate these children, that we find that they have normal investigation, as I've discussed, except they can have some thrombocytosis. So we don't need to worry about this child. It is a simple case of IgA vasculitis, but it is not so. So whenever we see a child of IgA vasculitis, we should be aware of the fact that IgA vasculitis nephritis can have, majority of these children can have asymptomatic presentation. So we should not forget to screen them for nephritis by doing a simple kidney function test and urine analysis. And apart from that, we should believe our clinical examination by taking the blood pressure, and it should be normal. So this is the important part that we have to take care. So with this, we have come the second most common organ which is being affected in HSP, that is the musculoskeletal involvement. It is almost involved in 70 to 80% of the children, and here arthralgia is a more common complaint than arthritis, and if at all arthritis is seen, it is primarily a periarticular involvement, so hardly we see effusion in these children. A lower limb joint involvement are most commonly seen, but what is the important point to remember about HSP is the variety of presentation that we see. Sometimes they can be arthralgia preceding the onset of purpura, and it can proceed by a duration of week in less than 25% of children, so that is can be a clinically challenging situation where we may need to keep this into the mind as well. So we know the skin is the most commonly affected organ. Almost 100% cases have purpura, and I think this is the most important clinical feature that helps in differentiating us from other differentials. And we know that most commonly we can have this distribution of these rashes over the lower limb, on the dependent regions of the body, or on the pressure points. That's why if we see a younger kid who has got HSP, is more like to have the distribution over the buttock, because these are the pressure points or on the lower limbs as compared to older child. So, but sometimes we can have atypical involvement as well. So what if they have involvement of the upper limb, or if they have involvement of the trunk, or they have just necrotic like lesions? So we have to be alert in such situation as well. We need to think about other alternative diagnosis. And if I talk about the rheumatic condition that I need to keep into the mind, that it may be ANCA-associated vasculitis, or as vasculitis associated with various connective tissue disorders like lupus or JDM. So I'm talking about a very mild variant of this disease that we see in younger kids, called acute hemorrhagic edema of infancy. So it is mild. It is the most mild variety because it is self-limiting in nature. We may not need to treat the disease, and it does not carry any long-term poor prognosis. But what is important to remember about this condition, it is nice to see the SPIC and label it at acute hemorrhagic edema of infancy, but sometimes they can closely mimic the rashes of Kawasaki disease. Sometimes they can mimic like a urticarial vasculitis or a dermatological condition like erythema multiforme. In that situation, we really need to go through the clinical details, and accordingly we can reach to the diagnosis. So with this, we move to our second case. This is again a boy who's following the common age group. He is a 4-year-old boy. He had few petechial rashes. It might be visible in this photograph that the rashes were limited to the feet only. He had few petechial rashes, no classic purpuric rashes in this child. And he had some arthralgia. Apart from that, on examination, we found the swelling of the hand, and not only swelling of the hand, there was swelling of the back, big swelling of the back. So it was a very atypical presentation that we saw in this child, few petechial rashes with angioedema, big angioedema swelling over the back. And so in this case, we had a lot of differential to keep in this child, and most commonly we kept hematological condition like ITP or malignancy. Are we missing these sinister causes in this child? And so I have enlisted the various factors that we looked into this disease. So what happened in malignancy, sometimes they can have lymphedema that can mimic that angioedema we can see. So this child was actually a conundrum for us. So we investigated and we found that he had nothing to reveal about the hematological condition, and it was a case of HSP. So we need to go into the clinical details again and again, repeat clinical examination, and we have to interpret our investigation to arrive this condition sometime. So with this, I move to the third case. It is, till now we were talking about the children who are presenting in the common age group. This boy, this is an adolescent boy who was admitted with the complaint of bullae and blisters on hands, feet, and also on the inner aspect of the lip. And a day later, he had purpuric rashes and also had colicky abdominal pain. And on examination, we also found he had arthritis of both the elbows. So this child is not at all following the typical clinical presentation of HSP. So we investigated him thoroughly for various other differentials as well. And to our surprise, everything was normal. Only ESR, CRP were elevated. And so we worked for lupus also. Complements were normal. ANA by indirect immunofluorescence method was negative. ANCA for PR3, MPO by ELISA were also negative. So we went ahead with the biopsy. So these are the clinical situations where we have to think, should we go ahead with the skin biopsy or not? So we found the child had leukocytoclastic vasculitis. On DIF, he had granular IgA deposits. So this child had atypical IgA vasculitis. So as per 2008 Ankara Consensus Conference, this criteria has been added to show the IgA deposition in a biopsy sample who have atypical distribution of purpura or who have blister-like lesions. So blistering eruptions are more commonly seen in adults. It's not commonly seen in children. If at all it is seen in less than 2% of the population. But if you look at the literature, they say they have the same type of presentation, and the prognosis and remission is similar to that of purpura. So with this, we have come to know about other rheumatological conditions which can mimic. So this is about an 11-year-old boy who had these vasculitic rashes on the leg. We went ahead with the skin biopsy and it showed leukocytoclastic vasculitis. So, but it was not easy to say that this child is case of HSP. So we went into the history and tried to dig out what he had. So on taking detail, we found that he had constitutional symptoms of low-grade fever, weight loss, easy fatigability. He had vasculitic rashes over the eye, hard palate ulcers. Then later on he developed arthritis and vasculitic rashes over the lower limb. So this child had childhood onset SLE. So we have to know the various type of clinical presentations other rheumatological conditions can have. The second most common organ to be affected is gastrointestinal tract system, and it is seen in around 60 to 70% of the cases. The whole GIT can have vasculitis in these children. But the most important point that they are the common cause of surgical intervention as well. So the most common surgical complication that we see in these children is intussusception. Apart from that, we can have perforation, necrosis, or massive GI bleeding depending upon the severity of the GI vasculitis. So this third case had GI manifestation, which I discussed, and he had frank GI bleeding. We went ahead with ultrasound thinking it could be intussusception, but it was not there. The gastro team went ahead with the endoscopy because they had a doubt about inflammatory bowel disease, but the child had purpuric rashes, so we didn't think about it. But sometimes there can be GI manifestation, can be the first presentation, so child can present with bloody diarrhea. In that, we need to keep the differential of early inflammatory bowel disease and how to differentiate these two conditions. On endoscopy biopsy, we found that there is erosive duodenitis, which is a characteristic feature of HSP vasculitis as compared to inflammatory bowel disease. So this is my last case. So this is a 6-year-old girl who had acute colicky abdominal pain for last 3 days. Child was seen by pediatric surgeon who diagnosed as appendicitis and underwent laparotomy. But on doing laparotomy, they found only purpuric lesions all over the intestinal loops, and few days later, this child developed purpuric rashes over the lower limb and arthralgia. So there can be sometime acute appendicitis can also be a presentation, but what the literature says that most of the time they have simultaneous onset of purpuric rashes, but in rare instances they can be absent of those rashes also. So GIT involvement is the second most common organ to be affected, but it can also precede the HSP by 2 weeks in around 20% of the children. Then it can be again a clinical conundrum to diagnose this disease. And abdominal ultrasound is the best initial diagnostic modality to assess GI involvement and complications. So if we talk about the renal involvement is the least commonly affected organ, but carries the most important. It is the most important organ to be discussed because it carries the long-term prognosis. And it is, as I said, it is usually has asymptomatic presentation, so active screening is required, and most commonly it presents with isolated microscopic hematuria, and that to occur within 4 weeks of onset of the disease. So around 85% of the children who are having IgA vasculitis nephritis are going to present within 4 weeks of the onset of the disease, and 97% will manifest within first 6 months. So we should be actively screening these children for the first 6 months of the disease. So this is the last case pertaining to the last organ which is affected. So this is a 13-year-old girl who had upper respiratory tract infection. 4 weeks later, she had purpuric rashes over arms and legs and pain in ankle and knees. On examination, her blood pressure was normal, throat was normal. She had only purpuric rashes and nothing else to be noted. In the blood, we found that she had a lot of findings. So she had thrombocytosis, high inflammatory markers, and apart from that, her urine, as I said, most of them have IgA vasculitis nephritis have asymptomatic findings. So this child similarly had asymptomatic urinary abnormality. So she had active sediments in the urine, and her spot urine protein to creatinine ratio was also elevated. Now in this case, we have a lot of things to be discussed with the kidney biopsy to be done. Can it be a acute post-streptococcal glomerulonephritis? So as per the organ affection, we may need to change our differentials. So in the first case, we had hematological condition had upper hand, and here we have to look for the various other differentials of kidney involvement. Again, we went ahead with the other causes evaluation, and here we found that ASO titer was significantly elevated. So as we know in HSP, many times it can be post-streptococcal infection induced HSP as well. So in the differential, we had lot of differential to keep in this child. Can it be IgA nephropathy or acute post-streptococcal glomerulonephritis, or could it be childhood onset SLE? I've already discussed about the SLE kids, how do they present. So acute streptococcal glomerulonephritis was a common differential, was a close differential to this disease, but C3 was normal in this child, which goes against this, and also they present earlier, they don't have a latency period of 4 weeks. Another important differential to talk in this child is, who is 14-year-old, had glomerulonephritis-like feature, is can it be ANCA-associated vasculitis? So how does a child of ANCA-associated vasculitis present to us? They usually have a preceding chronic history of sinusitis or ear discharge, or they can have constitutional symptoms followed by purpuric rashes, and then they can have manifestation like of the pulmonary involvement in the form of cough or breathlessness of edema. So like this child had thick walled cavities and superimposed by diffuse alveolar hemorrhage, and also the blood showed that C-ANCA and NTPR3 was positive. So in this child, I said we had a lot of things to be discussed. So should we go for kidney biopsy in this child or not? So as per the literature, kidney biopsy should be done in the conditions where they have severe persistent proteinuria for at least 4 weeks. So we didn't go ahead with the kidney biopsy, and child received steroid and proteinuria settled in 4 to 6 weeks. So how to differentiate these children on kidney biopsy? So as I discussed, that we will find diffuse mesangial IgA deposits, and there will be also lack of deposition of C1q on C4 complement molecules, because alternative complement pathway is activated in this disease. With this, I would like to end my presentation. Thank you.
Thank you, madam, for an excellent presentation. Any questions?
Again, please clarify how to differentiate between IgA nephropathy and IgA vasculitis-induced nephritis.
Sir, actually, if we talk about the literature, then it seems to be the spectrum of, it seems to be the two diseases of the same spectrum. Only difference, one develops purpura, other doesn't develop the purpura. And so other important thing that we can say that sometimes complements are, in majority of the situation, if it is significant nephritis, then complements are low in case of HSP, but in case of IgA nephropathy, complements are normal.
Because why I'm
and
asking,
other thing is, if we have a preceding history of upper respiratory tract infection, then IgA nephropathy is more likely to have a shorter latency period of maybe 2 to 3 days following upper respiratory tract infection. And sometimes they are also accompanied by loin pain or gross hematuria is a more common presentation to them.
because one thing, you see, nowadays SGLT2 inhibitors are more and more used in case of IgA nephropathy. Okay? So I don't know whether this can be used in these conditions where they do not at least improve within 3 to 6 months, because you see SGLT2 inhibitor are also approved for 10 years and above the age group.
Okay. So I didn't get the question.
Thank you so much, madam. I think we can go to the next talk.
Just to support her answer, IgA nephropathy is affecting only one organ, that is kidney. But HSP, skin, joints, and intestine. So IgA nephropathy is a local disease, and it is a systemic disease, and both sharing the same pathology.
Thank you, ma'am, for sharing your insights with us.